A very good evening on behalf of NTSI. I welcome you all. So, our today's topic, today's master class is we are tackling a critical topic in neurosurgery, neurotrauma, that subaxial cervical spine trauma. So, as we know, like while upper cervical injuries, particularly at CVJ, that frequently dominate the textbook chapters and frequently dominate the entire spectrum and discussion. But it is the C3 to C7 that bears the burden and the brunt of high impact injury. So we have a wonderful panel of panelists today and speakers. So I'll introduce first speaker will be Dr. Mayank Tripathi. He is a senior consultant in Horizon Hospital, Raipur, and he will be speaking on anatomy and physiological basis of subaxial cervical spine. Uh, Dr. Ved Prakash Maurya, he is additional professor in SGPJ Lucknow, and he will speak on management of subaxial cervical spine injury. And then we have Neurotrauma Society of India President, Professor Sumit Sinha, Vice Chairman of Max Super Speciality Hospital. And sir will discuss difficult cases. And we have esteemed panel, Dr. Jagatlal, he is professor in Rajgiri Hospital, Kochi, and Dr. Bernard Lingdo from Multi-Speciality Hospital, Shillong, and Professor Kuldeep Yadav from RML Lucknow. Our secretary, Dr. Deepak Singh, he could not join due to some commitment. So, and we have Dr. Professor Subhas Konar from Nimans, along with who will be moderating. So, I think we can start, Dr. Mayank. You can start sharing your presentation.
Yes, sure. So the slide is visible, sir.
Yeah, it's visible.
So very good evening. I thank the members of the organizing committee to for giving me this opportunity. So I shall be discussing the anatomical and the physiological perspective of subaxial cervical spine injury. A brief overview. I'll start with the introduction, then we'll discuss the anatomy, and then the biomechanics of the injury, the classification systems, and the references. So as we all know, the subaxial spine is from C3 to C7. It is significantly distinct from the C1 and C2 and the CVJ junction. So it is viewed as a separate entity. When we come to the osseous anatomy of the subaxial spine, we know that the spinous processes of C2 to C6 are bifid. And with the C7 spinous processes being a single one, which is the most prominent and is also known as the vertebra prominence. The facet joints of the subaxial spine have an 30 to 40 degree inclination on the sagittal view. The most peculiar thing of the subaxial spine is the presence of the uncinate processes, which is nothing but the lateral projection of the vertebral body, which form the ancovertebral joint and are also known as the joints of Lashka. These ancovertebral joints are responsible for providing the extra stability in the subaxial spine. So this is the C3 inferior aspect, as we can see in this diagram. This is the C3 vertebra with the vertebral body. These are the transverse processes which have the foramen transversarium through which the vertebral artery passes. And the foramen transverse anterior to the foramen transversarium, there is presence of the anterior and the posterior tubercle. These are the pedicles, and posteriorly we have the lamina, and this is the bifid spinous process. One important thing which has been mentioned in the literature is that the C6 anterior tubercle is also known as the carotid tubercle or the tubercle of Cheshire. The classical importance of this tubercle is that while going through the anterior approaches, we can palpate the carotid artery against this anterior tubercle of the C6 vertebra. And if there is an inadvertent injury to the carotid artery can be compressed toward this tubercle to stop the bleed. Now, this is the C7 vertebra, superior view. Here we can appreciate that the spinous process in the C7 vertebra is single, it is not bifid usually. And the foramen transversarium of the C7 vertebra do not transmit the vertebral artery, as the vertebral artery enters through the C6 and passes through the other foramens and passes out from the C2. The C7 foramen transversarium usually give place to the venous plexus, and it can have septations also, which is very prone to anomaly. Then we have the facet joints, which are also known as the zygapophyseal joints. These are basically the synovial joints and are formed by the articular processes of the adjacent vertebra. And they have a sagittal orientation of 30 to 45 degree. And one important thing is that as we go from below upwards, that is from C7 to C3, the inclination increases. These joints tend to be more vertical. So, if we look at the facet joint orientation in the axial view, it is known that the superior facet usually faces posterior-medially in the upper subaxial spine, but as we go downwards, these facet joints usually turn posterior-laterally. This is the anatomy of the lateral masses of the subaxial spine, which is nothing only but the pars interarticularis. Here we can see in this image the classical which has been taken from the AO Foundation, that this is the process of putting the screws in the lateral mass. For putting the screws, the lateral mass is divided into the four quadrants, and the most safest entry point being the superomedial one, which is classically the Magrel's technique. Other techniques like Roy Camely have been also described, but the most safest entry and the trajectory for lateral mass is the Magrel's technique. Then this slide shows the ligamentous anatomy of the subaxial spine. This is a sagittal view. These are the vertebral bodies with the anterior longitudinal ligament, and this is the posterior longitudinal ligament. The intervertebral disc between the two vertebra, and posteriorly we have the interspinous ligament, the supraspinous ligament, and the nuchal ligament is not visible in this diagram. We'll see later. And the lateral ligamentous structures, we have the ligamentum flavum and the facet joint capsule. This is an MRI T2 image, sagittal view of the subaxial spinal structures, which depicts the different ligamentous anatomy. This is the anterior longitudinal ligament, the posterior longitudinal ligament, the ligamentum flavum, the interspinous ligament, and the supraspinatus ligament. Here we can appreciate the ligamentum nuchae, which starts from the base of the skull near the inion, attached with the median nuchal line, and goes inferiorly to attach on the subaxial spinal processes. The vascular anatomy. As we all know that the subaxial spine harbors the vertebral artery, which arises from the subclavian, enters to the foramen transversarium of the C6 vertebra, passes through C5, C4, and C3, and exits near the C2 to cross over and passes superiorly over the arch of C1. And then it enters into the dura, becoming intradural, and forms the basilar artery. It is found that usually the left vertebral artery is dominant in majority of the patients. And if we look at the anatomy of the foramen transversarium in the three-dimensional space, the foramen transversarium gradually moves anteriorly and medially as we go from C6 to C2. Then if you look at the vertebral artery anatomy, as we have discussed, it enters from C6, but in 85% of the cases, but in 8% of the cases, it may enter at C8 also. And 15% of patients have different level of entry of the vertebral artery. And the vertebral artery as an anomaly may also pass extraforaminally anterior to the vertebral body. Now discussing the biomechanics of the injury. The OC1 joint is responsible for 50% of all the flexion extension movement. The C1, C2 joint is responsible for 50% of all rotational movements. Now, what is the main movement at the C3, C7 joint is the remaining half of the flexion, extension, and the rotation movement. Apart from that, occurring at the OC1 and the C1, C2 joint. and nearly all lateral bending occurs at the subaxial spine level. There are three common mechanisms of injury. The first is the hyperflexion, which is most commonly a result from the motor vehicle accident and fall. There, when the motor vehicle is hit from the front, there is like distraction in the posterior elements and compression in the anterior column. The second mechanism of injury is the axial compression, which results from the axial loading. The injury pattern depends upon the initial head position. It may result into the burst, wedge, or compression fractures, which is more commonly results from diving injury, motor vehicle accidents, and active sports like playing football. And the third mechanism of injury is the hyperextension, when a motor vehicle accident occurs, when the vehicle is hit with a high velocity from the posterior. And there is impaction in such an injury. There is impaction of the posterior elements like the posterior elements like lamina, spinous process, and the pedicles get impacted, and there is disruption of the anterior elements like ALL. So, for instance, cervical spine injury, when do we need imaging? The two criteria have been described classically, which are the nexus and the Canadian C-spine rule. Like if, according to the nexus criteria, if there is no posterior midline cervical tenderness, there is no evidence of intoxication, there is normal level of alertness, no focal neurological deficit, and no painful distracting injuries. So if the patient follows or if the patient is fulfilling all five criteria, there is very low risk of cervical spine injury, and such patients do not need a C spine X-ray. For all other patients, an X-ray cervical spine is indicated. Now, the next is the Canadian C-spine rule, which is more specific and specific and sensitive for diagnosing the cervical spine injuries. For the Canadian C-spine rule, we basically look at the three high-risk factors, which are age, if more than 65 years, there is dangerous mechanism of injury, or the patient has paresthesia in the limbs. If any of these is positive, then we go for an radiographical imaging. Then, if none of these is positive, then we look at the low risk factor, like the simple rear end motor vehicle collision, or the patient is in the sitting position in the emergency department, the patient is ambulatory at any time, or there is delayed onset of neck pain, or there is absence of midline cervical spine tenderness. If none of these are positive, like for the first category, if any of these was positive, we had to go for an X-ray. And after looking at the low risk factors, if none of these are positive, we go for an radiological imaging. And if any of these is positive, then we clinically examine the patient and look at if the patient is able to actively rotate the neck, like if the patient is able to move the neck 45 degrees left or right. If the patient is able, there is no need of radiological imaging, but if the patient is unable to move the neck, then we go for a radiological imaging. This is a simple X-ray lateral view of the subaxial cervical spine. What we can see here is the vertebral body and the anterior element. Here we can appreciate the anterior annulus. This is the facet capsule. These are the facet joints. And this is the interspinous ligament and the ligamentum flavum. So various classification systems have been proposed for classifying the injury classifications. I would just briefly touch the first five because they have only historical significance. The main classification systems we routinely use is the subaxial injury classification and the AO spine classification system. The Holdsworth classification system was proposed in the year 1963 by Holdsworth et al. And it had a two-column concept. They divided the spine into two columns, the anterior and the posterior column. The vertebral body and the disc form the anterior column, and the neural arches and the posterior ligamentous complex form the posterior column. As per the Holdsworth classification system, the integrity of the posterior column was a major determinant of the spinal stability. As per this classification, five patterns of trauma could lead to fracture or dislocation in the subaxial spine, which were flexion, flexion rotation, extension injuries, compression, and the shear injuries. After the Holdsworth came the Allen's mechanistic classification in the year 1982. As per this classification, the translation of the kinetic energy into the fractures or dislocation in the cervical spine depended upon two independent variables. The first was the injury vector, and the second was the posture of the cervical spine at the time of injury. As per this classification, there were six types. Compressive flexion, vertical compression, distractive flexion, compressive extension, distractive extension, and lateral extension. Then in the year 1986 came the Harris classification system. It had seven different mechanisms of injury. It was a more detailed classification which included multiple subgroups, like the flexion injury were divided into five subgroups. And the vertical compression had two subgroups. The hyperextension had seven subgroups. It was a more detailed classification at that time. Now, what we have seen in these classical three classification systems were based only on the mechanism of injury and the resulting uh, distortion of the bony abnormality. There was no comment upon the status of the neurology of the patient. For the first time in 1990, that is White and Punjabi clinical checklist came, which took into consideration the status of spinal cord injury, nerve root injury, keeping in consideration the neurological status of the patient. According to this checklist, the and different points were given. Like if the anterior elements were destroyed, 2 points were given. 2 points for posterior elements destruction. If there was a relative translation of more than 3.5 mm in the sagittal X-ray, 2 points were given. If there was relative sagittal plane rotation of more than 11 degrees, then 2 points were given. The patient had a positive stretch test. The cervical spine was stretched under controlled condition and looked for the increase in the space between two vertebrae. That was the positive stretch test. If the patient for this 2 points were given, and for spinal cord injury, then again 2 points. The nerve root injury, 1 point each were given for the nerve root injury, abnormal disc narrowing, and anticipated dangerous mechanism of injury. As per this checklist, if the score was more than equal to 5, it was suggestive of instability in the cervical spine. Then in the year 2007 came the cervical spine injury severity score. It was given by Anderson et al. It divided the subaxial cervical spine into four elements, which were the anterior element consisting of the vertebral body, ALL, annulus, and the PLL, and right and left facet joints with their capsules, and the posterior element were the lamina, the spinous process, the interspinous ligament, and the supraspinous ligament. So as per this classification system, depending upon the extent of the skeleton and the fracture light separation, which was given a grade from 0 to 5 mm, each column was given a score of 0 to 5. So therefore, four columns were present, so the collective score was 0 to 20. So, like if the separation was 1 mm, a score of 1 was given. If the separation was 4 mm, a score of 4 was given. And for all different four columns, the score was total, and if it was less than 5, the patient was non-operative. If it was the 5 to 7, it was the surgeon's decision, and if the score was more than 7, the patient had a surgical indication. Now, the subaxial injury classification system, which we most commonly use, these are the two latest, the AO spine classification and the subaxial injury classification system. The subaxial injury classification was proposed by Vocaro et al. In the year 2007. It took into consideration three components. It was the injury morphology, the status of the discoligamentous complex, and the neurological status of the patient. So this is a table showing this SLIC classification. Like different points were given for the injury morphology. For 1 for compression, 2 points for burst, 3 for distraction, 4 for rotational or translational injury. And importance was also given to the discoligamentous complex. If the score was 0 was given if the discoligamentous complex was intact. 1 for suspected injury, 2 for disruption. And then the neurological status of the patient was also taken into consideration, which was separate, which was a new thing. As like the previous classification system took into consideration only the mechanism of injury and the anatomical distortion. The neurological status was considered. If it was intact, a score of 0 was given. The nerve root injury was given a score of 1. The complete cord injury, a score of 2. Incomplete cord injury, a score of 3. And persistent cord injury, a score of +1 was given for all these. So after totaling, if the score was 1, 2, 3, the patient was had a non-surgical indication. A score of 4 suggested surgical or non-surgical, depending upon the preference of the surgeon. And a score of 5 or more had a surgical indication. So briefly, I should be discussing the mechanism of the morphology of the injury given by the SLIC classification. The compression in the compression injury, there was a visible loss of height through part of the vertebral body or disruption through the end plate. Whereas in the distraction injury, there was anatomical dislocation in the vertical axis. It included both the flexion and the extension injuries. And this is the rotational and translational injury. There, as per this, there should be an horizontal displacement of one part of the subaxial spine with respect to the other. And for the evaluation of the discoligamentous complex, these are the examples like what could be the injury to the discoligamentous complex. For example, abnormal widening of the anterior displace, abnormal facet alignment, signal intensity changes on T2 sagittal MRI in the disc space, or widening between two spinous processes. This is an MRI T2 sagittal view showing for the example on how the injury of discoligamentous complex looks like. Like the pointer at 1 shows the injury. There is a stripping of the PLL posterior to the vertebral bodies, but the PLL is intact in this case. But at the marker 2, we can appreciate that there is a disruption of the posterior ligament, posterior longitudinal ligament with herniation of the disc contents posteriorly. At 3, here we can appreciate the flaval ligamental tear, and this is what splaying of the dorsal spine and the interspinous ligament looks like. According to the SLIC classification, the neurological status was considered the most important, and it was the single most influential predictor of the treatment. And then in the year 2013 came the AO spine classification. It classified injuries into different types. Like type A was compression injuries, type B was tension band injuries, type BL was bilateral injuries, type C was translational injuries, and type F was facet injuries. Now, if we look at the AO spine classification, and the type A injuries, which were compression injuries, could be grouped into 5 different groups. The AO was minor non-structural injuries, which involved the injury to the spinous process or the lamina only. And type A, they were compression fractures involving the single end plate without involvement of any posterior wall or the vertebral body. In type A2, there was split, coronal split or fractures which involved both the end plates, but the posterior elements were intact. In type 3 were the burst fracture, type A3 was incomplete, and type A4 was a complete burst fracture involving both the end plates. Now, if we look at the type B, which is the tension band injuries, type B1 was the physical separation through any fractured bony structure only. Like if there was only bony injury, it was type B1. In type B2, there was posterior tension band injuries involving both the capsule ligamentous and the bony structure. There could be injury to the ligamentous injury also, or along with the bony injury. In type B3, there was anterior tension band injury. BL was given for bilateral injuries. In type C AO classification, it included translational injuries in any axis and displacement or translation of one of the vertebral body relative to the other in any direction. Type F were the facet injuries. It had 4 different categories. The F1 was non-displaced facet fracture with a fragment height of less than 1 centimeter with less than 40% lateral mass involvement. Type 2, F2 fracture is facet fracture with potential for instability. That is, the fragment length is more than 1 centimeter, or there is more than 40% of the lateral mass involvement. Type F3 is the floating lateral mass fracture, where there is fracture of the ipsilateral lamina and the pedicle. And type F4 is the burst or the dislocated facet. The AO spine classification also takes into consideration the neurology of the patient. It has different numbering from N0 to NX. And it also takes into consideration the different modifiers. Like if the posterior capsular ligamentous complex injury is there without complete disruption, then M1 is given. If there is critical disc herniation, then M2. And if there is stiffening or any metabolic disease, then an M3 point is given. And if there is any vertebral artery abnormality, then M4 was added. So these were the major classification system, and we most commonly use the SLIC and the AO spine classification. So these are my references. Thank you.
Thank you, Manak, for your nice detailed presentation.
Thank you, sir. Thank you.
We'll just go through and then we'll discuss at the end.
Sure, sir.
So, with the permission from panelists, I'll invite the next speaker, Dr. Ved Prakash Maurya, who will be discussing about the management. So, we'll have a anatomy and mechanism and management. Hello.
Yes, sir.
Ved, you can share your.
Yeah, please proceed. Proceed.
Is my slide visible, sir?
Yes, visible.
Okay. Very good afternoon. Very good evening. First of all, I am very thankful to the organizing team of Neurotrauma Society of India for giving me this opportunity to speak on this webinar, revisiting the subaxial cervical spine injury. So I will be speaking on management of subaxial cervical spine injury. First of all, I thank my first speaker, Dr. Mayank, who has made my job much easy, because in my initial half slides have been taken care by Dr. Mayank only. So as we all know that subaxial cervical spine includes C3 to C7 cervical vertebra. And as we know that these are very mobile segment, and these mobile segments are very prone for significant amount of injuries. And the injuries are predominantly dominated by road traffic accident, which accounts for nearly 2/5 of the total amount of fracture of the spine, fall from height around 30 to 35%, and sports impact related injuries, where it leads to the third most common cause of subaxial cervical spine injury. Osteoporosis and spondyloarthropathies are next in number, which accounts for other group of subaxial cervical spine injuries, and they relatively requires lower energy as compared to the former mode of injuries as discussed above, because they happen in the pathology or in the advanced age group. 2/3 of these cervical fractures, it contribute about subaxial cervical spine, and nearly 75% of all dislocations are contributed by subaxial cervical spine injury. We should have high index of suspicion to early detect these injuries and treat these cases. Just quickly touching the evaluation, how to evaluate the patient of subaxial cervical spine injury. Initial evaluation in any suspected cervical spine trauma should be managed by protocols or guidelines of advanced trauma life support, where each and every healthcare provider will speak a common language, that is A, B, C, D, E, so that subaxial cervical spine injury, or for that matter, any spinal injury, should not be overlooked in view of other injuries. Neither it should be overestimated and ignoring the other injuries. So it should be optimally addressed, and if we follow the common language, it will never be missed. So by following that protocol, there should be adequate spinal immobilization by using the cervical collar. Poor immobilization can lead to second neurological incident in about 1/4 of the cases, and detailed examination and providing American Spinal Injury Association grading system, which helps us in proper documentation, diagnosis, as well as prognostication of these cases. What are the diagnostic modalities of these cases? In aware, alert, oriented patients with no current or history of neurological deficit, without having any destructive injuries and no pain or no restriction to the range of motion, the collar should be removed without any further imaging. But this protocol has been validated by National Emergency X-ray Utilization Study, that is NEXUS, which is having high negative predictive value of 99.8%. For high-risk patients, computed tomography is the initial screening study of choice. MRI is indicated in patients with a neurological deficit. If we are planning to intubate a patient, we should intubate the patient after getting the CT scan, or it should be followed according to advanced trauma life support. Then we should get the magnetic resonance MRI of the cervical spine. Due to possibility of clinically meaningful injuries missed on the CT, it becomes mandatory that we should have MRI of the spine. What are the role of steroid? In spinal cord injuries, the role of methylprednisolone has been controversial. There have been studies of National Acute Spinal Cord Injury Study 1, 2, 3, where they have finally concluded that a dose of 30 mg per kg for the first 4 hours for patients with injury within 4 to 8 hours, followed by 5.4 mg per kg per hour for 23 to 48 hours can be given, but it comes with the risk of significant side effect and poor wound healing. Classification of subaxial cervical spine injury, which has been very well covered by Dr. Mayank, I will just touch upon. First, description of cervical spine injury given by Bowler described injury morphology based on the plain radiograph. Also describe injuries based on mechanism of injury and focus on the concept of stable versus unstable injury, on the importance of posterior ligamentous complex. Allen and Ferguson classification describes 6 injury types: compressive flexion, vertical compression, distractive flexion, compressive extension, distractive extension, and lateral flexion. Harris describes the mechanism based on the injury system. The subaxial classification, injury classification and severity scale developed in 2007 by Spine Trauma Study Group to combine the various aspects as discussed earlier of previous systems and introduce suggested treatment algorithm based on the scoring system, because it is a diagnostic as well as a prognostic scoring system. This system characterizes injury based on morphology of the injury, discoligamentous complex, which is reviewed on the radiology, and neurological status, which is assessed clinically. This is the standard components of the subaxial cervical spine injury classification. It guides the treatment and predicts the prognosis. It is recommended by World Federation of Neurological Societies. It is composed of 3 parameters, as we have told: injury morphology, discoligamentous complex integrity, and neurological status. 1, 2, 3 is non-surgical. 4 or more than 4 is surgical category. AO spine classification, which is most widely practiced, we have discussed. Subaxial cervical spine injury, it is published, latest is 2016, demonstrated better agreement than the Allen and Ferguson scheme, and adequate inter-observer and intra-observer reliability. The most important thing is inter-observer and intra-observer reliability, and there is minimum discrepancy, and both neurosurgeons as well as spine orthopedic surgeons, they come to a common page by using this orthopedic AO spine classification. As it discussed, type A is compression injury, type B is tension band injury, type C is translation injury. This is the difference of the AO classification. Compression AO, minor non-structural fracture, A1 wedge compression fracture, A2 split fracture, incomplete burst is A3, A4 is complete burst fracture. Tension band, B1 posterior tension band injury, B2 posterior tension band with a capsuloligamentous injury, B3 anterior tension band injury, and if there is bilateral injury, it is classified as B3, BL. And third is most dangerous one, most unstable, is translational injury. In any axis, displacement or translation of one vertebral body related to another. And type 5 is facial injury, that is stable fracture, F1, F2 is unstable fracture, floating lateral mass, F3, Pathological subluxation, purged or locked facet or dislocated facet is F4. The posterior ligamentous complex commonly injured to varying degree with destructive type of injuries. These include injury to supraspinous and interspinous ligaments as well as the capsule of the facet joint. The facet joint capsule integrity can be differentiated minor injuries for more significant unstable injuries. That's why MRI become mandatory in these cases. But there are studies which shows that even the integrity of the facet joint capsule has been missed in several cases, even with MRI. So what is the goal of our treatment? So goal of treatment for subaxial cervical spine injury is to decompress the spinal canal as soon as possible and alleviate the compression from the neural element if necessary. Provide stability in order to facilitate early mobilization and prevent late displacement and deformity. So what are the non-operative treatments? In stable injuries, as we discussed, without any neurological compression, we should not operate the patient. We should manage the patient non-operatively. Minor injuries such as spinous process fractures without significant discoligamentous injury, cervical orthosis can be given and it is sufficient. Soft collars to the more rigid Aspen collar, that is Aspen Medical Products, or Philadelphia collar and Miami J collar are other modalities which provide significant cervical orthosis. Cervicothoracic orthosis are effective for limiting the motion in the sagittal plane by extending from the cervical spine to the rigid thoracic spine. The hollow waist is most restrictive to cervicothoracic orthosis, but it comes at a significant risk of complications such as bed sore and pressure compressions. So we should use it judiciously. What are the surgical options? Unstable injuries with or without neurological deficit should undergo surgical intervention. Patient-specific variables like medical comorbidities, associated injuries, it should never be overlooked. Presence of ankylosing spondylitis, diffuse idiopathic skeletal hyperostosis, osteoporosis, history of previous surgery, they carry significant amount of weightage in the surgical intervention. So these should be well watched and worked up before going for surgical intervention. So what are the choice of surgical approaches? We can go for anterior approach or posterior approach or combined approach where we have to go from anterior plus posterior both. Operative room setup should contains intraoperative fluoroscopy or CERVICAL. Magnification is mandatory for cervical spine injury management. Even if we are operating anterior cervical discectomy and fusion, we should try to operate always under magnification and preferably under microscope, because magnification significantly increases the efficiency of the surgery and it will prevent devastating complications. And if the resource permits, we should operate under OARM or any type of navigation. OARM provides real-time imaging as well as navigation. So it increases the safety as well as accuracy of the screw insertion. SGPGI is fortunate to have this gadget recently in the armamentarium. So advantages and disadvantages of anterior versus posterior approach for subaxial cervical spine injury. We know that anterior cervical plating, where we do the discectomy, it augments the stabilization and provides a sordal fusion. It resists development of kyphosis, reduces the need for external bracing, and no graft extrusion. Minimal graft extrusion, we can't say more. Less non-union. Disadvantages, it increases the cost. Obviously, there is implant, so it will be costful. Requires special instruments. Screw loosening or fracture, infection, and neural injury are the risk. Rate of complication is high, 23% in some of the series. And if we go anteriorly, there may be risk of dysphagia and dysphonia because of injury to the recurrent laryngeal nerve. Interbody cage, what are the advantages? It prevents subsidence of the disc height. Increase of the cost is known disadvantage. Vertebral body cages, it replaces the body of the vertebra in case of burst fractures. It provides less subsidence than the bone graft. Cost is the limiting factor. In the posterior approach, spinous process wiring, no neurological complication is there, but need for intact posterior element is the mandatory. It is a weaker construct, especially in the rotational injury. Sublaminar wiring, Bolman triple wiring, laminar hooks. These are the posterior approaches. Lateral mass screw fixation, which is nowadays the surgical intervention of choice. then cervical pedicle screw fixation, and facet distraction cages. Advantage is more rotational stability, no need to preserve the posterior element because we are putting lateral mass screw, and pedicle screw provides a rigid fixation. It provides ability to reduce the subluxation and kyphosis. Disadvantage is they are semi-rigid fixation. Risk of screw loosening is there. Technically demanding, especially if you are putting pedicle screw in C7, and injury to the nerve root, dura, and vertebral artery. Efficient decompression is questionable in case of facet distraction cages. So these are some of the hardwares of anterior approach. These are the plates, first generation plate, and then these are second generation, which is semi compressible, and third generation, that is semi-constrainable. And this is the screw placement. The first image is showing bicortical purchase, second is monocortical purchase, and cranially divergent screw and caudally divergent screw to increase the length of the screw, to increase the pull-out strength of the screw in anterior cervical decompression and fusion. Pins are inserted in the vertebral body to decrease the kyphosis and remove the disc and elevate the compression over the spinal cord. The second image is showing divergent and convergent screw placement in the anterior cervical vertebra. This is generally we prefer the convergent screw because divergent screw have some chance of injury to the vasculature, that is vertebral artery. And posterior approaches, spinous process wiring, where we make a hole in the base of the spinous process in the adjacent vertebral body, in the adjacent spinous process, and pass the screw and tighten it to provide a posterior tension band. And we can also put a graft between the adjacent vertebral bodies, adjacent spinous process of the vertebral bodies, and we can also put bone pieces between the two facet joints also. These are the posterior approaches using wires. But nowadays, most important recommended is lateral mass screw fixation, which was very well described by my former speaker. And the entry point is center of the lateral mass, inferomedial 1 millimeter, and we should go around 20 to 25 degree cranially and laterally in lateral mass insertion. So it is generally safe in C3 to C6, and in C7 if we are using. So to connect the lateral mass, we can use the plate. Plate have a limitation that it is less mobile as compared to the rods. So generally rod is preferred and it can be bent easily. If we are putting the screw in the C7 or because of fracture, lateral mass is not accessible and we are putting the pedicle screw, then generally the medial inclination should be 25 to 45 degree at the medial angulation from C3 to C7. And from C5, C6, C7, we should go relatively parallel, and in C3 and C4, slight caudal orientation should be there in the sagittal plane. So this is a challenging situation where we can see that the lateral facets are purged and one is totally exposed. This is a situation where significant hyperextension injury is there and significant cord compression and almost transection of the cord is there in the MRI. We can see in the T2 weighted MRI, and there is locking of the C4, C5 lateral mass. So we can see that this is the inferior articular process of the superior facet and in superior articular process of the inferior facet. So the superior articular, the facet has jumped over the superior articular process of the inferior vertebra. So it is a jumped facet. A simple case capsule, 20-year-old gentleman who fall from terrace about 20 feet height. So we have operated him on the third day of the trauma. So when he came to our ED, what were the options? Steroid, already we have discussed that the role is controversial. Cervical traction, yes, the boy was conscious oriented, so we can put cervical traction. Timing of surgery, since there is obvious injury and there is locked facet, so we should operate him as soon as possible. Surgical approach, anterior approach, only posterior approach, or anterior approach, both anterior versus posterior approach. So there is significant amount of injury with hyperextension and translation injury, so we went for combined approach. This was the pre-op investigations. This is the patient was positioned anteriorly with cervical traction applied later on. So we went ahead with anterior decompression, and then posteriorly we can see that the facet joint is exposed. It is being reduced and lateral mass are placed. This is the anterior view of the surgical intervention where we have put a plate with cage, and this is the intraoperative X-ray showing the 360-degree fusion of the patient. Special situation is like cervicothoracic junction instability, where the injury is in the C7T1. So we have to include, the construct will include lower cervical and the upper thoracic junction. So the factors that increase the difficulty are diagnosing the level which is involved, complex biomechanics of the transitional zone, surgical accessibility, and intraoperative decision making regarding the hardware. Because first thing is we should access from the anterior approach, then we should go posteriorly. In anterior approach, accessing the anteriorly, the clavicle and the manubrium sternum are the limiting step. These are the obstructions which will hinder our surgical corridor. So we should find out what are the surgical options we can go ahead. If we have to go to the thoracic level T2, we should give a lateral long incision so that we can go to the lower cervical vertebra and upper thoracic vertebral junction. If the surgical corridor is limiting, then we can give incision and we can do the manubriectomy upper portion. And if we want further more exposure, we can include the medial most portion of the clavicle resection, that is manubrioclaviculotomy. So, and that is anterior approach. And once we are going for posterior fusion, there will be significant difference in the position of the cervical pedicle and thoracic pedicle. And the size of the screw will also be different. So we have to put the connector rod and slide rod connector from the cervical to the thoracic rod. So this is the image which depicts that how cervical lateral mass and C7 pedicle has been inserted, screw has been inserted, then upper thoracic screw has been inserted and connected with the help of the connector. This is a surgical video of cervical corpectomy and fusion. So on examination, his power was 4/5. This is the radiology of the patient. He has multiple trivial fall. This is the surgical position with cervical traction. So we have planned to go ahead with a corpectomy to address the adjacent discs. So with 15 number blade, the adjacent disc has been incised and removed. With the help of disc punch. Initial part of the vertebral body is removed with the help of bone nibbler. And once half of the vertebral body is removed, we can use high-speed drill, preferably diamond drill. And later part of the drilling must be drilled with diamond only in order to avoid inadvertent damage to the dura and spinal cord. Copious irrigation should be done once we are approaching close to the posterior longitudinal ligament or dura. This is the undercutting of the bony spurs at the end plate. There can be incidents of sudden ooze from the venous plexus because once we decompress, the epidural plexus may start bleeding. After exposing the posterior longitudinal ligament, we can use the upcut 2 number, 3 number upcut to remove the posterior longitudinal ligament. Removal of the posterior longitudinal ligament in anterior cervical approach and anterior cervical decompression is mandatory, because until unless we remove the PLL, posterior longitudinal ligament, the decompression is inadequate. And sooner or later, the patient will come with recurrence of the symptom. Just trying to coagulate the epidural venous channels, looking for the completeness of the decompression by using ball probe. That is, any bony spur is remaining. Now placement of the cage after adequate measurement, and anterior cervical plate with screw insertion. As we can see, the direction of the screw is caudally and convergent. Now there is a locking. So we have put the enter screw locker. This is the lateral view and the anterior posterior view. He made an uneven full recovery, and there was recovery in the motor power, and there was improvement in the sensory complaints over a week's period. So what coming the complication? Complications can be implant or bone graft subsidence. Once the graft subsides, there will be significant dislodgement and disparity between the plate and the screw. Exposure-related complication like anterior exposure, there can be injury to the recurrent nerve, injury to the, if very non-operated carefully, then we can damage during exposure the esophagus. And in posterior approach, once the fracture segment is going to the and transverse cerium, we should be careful about injury to the vertebral artery. And while placement of the pedicle screw, we should take care that screw should not be malpositioned and damage the exiting nerve roots or spinal cord. Then, and neurovascular injury, as I have told. So take home message is subaxial cervical spine is a highly mobile segment, and this mobility comes at the cost of instability. If we follow the protocol-based evaluation of the patient, that is advanced trauma life support, chances of missing injuries are less, and further injury and progression of the injury will be eliminated. So goal of management should be decompression when necessary and stabilize to promote early mobilization and recovery process. These are my references. Thank you very much.
Thank you, Ved, for detailed presentation. Jagat sir, can you proceed with the next speaker?
Yeah, we'll proceed with the next case, no? Probably Dr. Sumit Sinha.
Yeah. So we'll invite our president of NTSI. Sir will be discussing about a few cases and his experience about the management of those cases.
Good evening, Professor Sumit.
Yeah. Hi, Jagat. Hi. How are you?
Yeah, good.
Good. Can you see my slides, sir?
Yeah, it's seen. It's visible.
Thank you so much for. I can hear some noise in the background. Can you mute your microphones? Yes. Oh, thank you so much. So wonderful dispositions of the previous two speakers. I would say that, I mean, it was fantastic, and this is one of my very, very favorite hotshot topics, both while in surgery and in teaching. And this is one of the very, very important in daily practice of a spine surgeon, because they are very common injuries as compared to the other injuries in the spine. The reason being that this is the mobile segment of the spine, and we encounter them very, very frequently in our practice. So what I will be doing is I will be showing some of the cases, and I will be summing up the management of these subaxial cervical spine injuries according to what already my previous speakers have told. So I mean, I need not to go into the very, very details about already which has been discussed, but what I shall be discussing is about the practical aspects as to what to do when a patient with a cervical spine trauma comes. So, of course, my talk will be entirely related to the surgical aspects as compared to, the non-surgical or whatever. So, starting with a slight recapitulation of the what has been already discussed, and this is very, very important because when a patient comes with a cervical spine trauma, we have to carefully see the X-rays of that patient. Number one, I always tell my residents and fellows, always in spine, as it is most important thing to study the X-rays, and that too dynamic X-rays, flexion, extension, lateral, and AP X-rays. None of the other imaging modalities is able to provide that much quantum of information as compared to when a cervical spine X-ray or a lumbar spine X-ray is there. And this, I'm not talking from my own sense. I have been taught by my own mentor and teacher, Professor Kale. He used to always say this: what is the X-ray? See the X-ray first. Once you see the patient, then you see the X-ray. Because X-ray, especially in the cervical spine trauma, it immediately categorizes the type of the injury. It immediately classifies the injury so that you can pick and choose your treatment with which your patient can get the most of the benefit from. And then you can get the CT scan, see the CT scan, and then if the MRI is indicated, do the MRI, and then what is the job of a surgeon is to classify these injuries accordingly into whatever categories they are falling, because this is the most important step. And why so? Because thereafter only you can choose what surgery is there for this patient. So to start with, broadly, there are 4 types of categories of injuries. One is the compression injury, the other one is the burst injury, the third one is the distraction injury, and the last and the most severe one is the translational or the rotation injury. So when I talk about the compression morphology, we say that this is the axial loading which is happening, and therefore what is happening is the compression of the vertebral body, and in that effect the superior or the inferior end plate gets fractured, and as you can see in the first figure, and whenever the axial loading is so much that both of them are fractured as well as the posterior wall of the vertebral body is also fractured, this comes into the burst morphology. And this is what I'm talking about is a sum up of all the Allen and the Holdsworth and the AOC system classifications, whatever has been told already by the previous speakers. So burst fracture is the middle column collapse. And this is what makes it an unstable injury. So when you see in an X-ray or a CT scan that the posterior wall of the vertebral body is fractured, is interrupted, then this is not a stable injury that you are dealing with, meaning thereby that you have to probably take care of it by some sort of instrumentation and fixation. Now comes the distraction morphology. Now there are more severe type of unstable injuries, and this distraction morphology, the vector forces are distracting forces. So what happens is either there is a osteoligamentous injury or a ligamentous injury through and through between the two vertebral segments. So they can happen either anteriorly, they can happen either posteriorly, they can happen through and through, also known as a chance fracture. So they can be all variants, all spectrum of these distraction morphologies, injuries. The last and the most severe form of injury, any injury, is the translational or the rotation morphology. So what happens, the force is so much that in addition to the disruption of the ligaments or the bones, there what happens is the sliding of one vertebra over the another, or the rotation of one vertebra over the another. So these are the highly unstable injuries which have to be fixed, come what may. What amount of fixation is required, it depends upon the patient's neurology. Suppose a patient is intact, then it will require a 360-degree fixation because you have to support while the patient is walking. If a patient is ASIA A or complete injury, then and poor GC, then you can get away by doing a anterior only or a posterior only fixation. We will shortly see in the coming slide. So with this background, the AO spine classification, I already discussed compression. There are three types of injury patterns: compression, distraction, and rotation. As you can see in this popular diagram, which has been shown already, I will not like to go into the details, but what I would like to go into the detail about this AO classification is, whenever you see an X-ray of any patient with this trauma, you have to answer three questions seeing that X-ray. Question number one, whether there is a displacement or a dislocation of the vertebral body with respect to the other vertebral body. Number two question is, what is the status of the posterior tension band? Now, posterior tension band is the ligament complex, which is considered to be the most important denominator, which is determining the stability of the spine. So if it is, I'm specifically talking about the posterior tension band, which is the most important factor in deciding about the stability of the spine. So when you see this tension band injury, you have to see whether this is an anterior tension band injury or a posterior tension band injury. The third question which you have to ask from yourself is whether a vertebral body is fractured or not. And if the fracture is present, whether the fracture is in the posterior wall, which makes it a type A3 or type A4 injury, or a burst fracture in other words, or whether the fracture is in the end plate. If it is in only the superior end plate, it makes it a A2 fracture. If it is in both the end plates, it makes it a A3 fracture. So this is how you classify mota. I mean, these three questions will help you in identifying and classifying categorizing your injury according to the set patterns set by AO spine classification. I hope I am correct. I mean, this is the most important slide of this all talk. Now, there are certain other neurology factors also which have been added by this AO spine classification, which have to be taken into account while deciding your treatment. And there are modifiers also. For example, in spondylitis, you have to take into consideration these metabolic bone diseases also, and because they modify your operative approach. So let's see. I mean, there are other classification systems also like SLIC scoring and all, which have been dealt with. I would like to highlight one important classification, which I very, very often use in my clinical practice. And this is what I came across several years before, and this was published in Global Spine Journal. And this is the German Society of Orthopedic Trauma, which is recommended. And this is based on AO spine, and this is based on the risk of progressive kyphosis if followed up in the long run. So what happens is, in this classification, what we measure is the end plate angle. So if suppose this is the, as shown in the illustration, this is the angle made between the superior and the inferior end plates of the vertebral segments of the area of interest. And there is, and this is the mean end plate angle, and this is the basic end plate angle, monosegmental end plate angle, and the bisegmental end plate angle if suppose two bodies are involved. And the difference between this angle and the normal lordosis is the delta end plate angle. So this is what delta end plate angle which we are interested in. And this is, they say that there are certain criteria of instability which they have defined, which is the facet joint subluxation of less than 50%, or fracture of the facet joint more than 10 millimeter, or the sagittal translation of the vertebral body more than 3.5 mm, and more than 15 degree of delta end plate angle, which makes it unstable and which is requiring a surgical instrumentation. So this is what this German society recommendations say about the fixation. So if I summarize now, according to the AO classification and the German society, what I use in my clinical practice is type AO fractures, A0 fracture, they are stable, and maximum which you require is a soft collar for maximum of 6 weeks. A1 fractures, they are stable fractures and they require again a soft collar for 6 weeks. Howsoever, you have to clinically follow up these fractures. And if suppose in the follow-up of these fractures, if the delta end plate angle progresses more than 15 degrees, then you should fuse, preferably an anterior monosegmental fusion is more than enough for these fractures. And similar for the A2 fractures, but here you have to require, because both the end plates are fractured, superior and inferior, so you have to do a bisegmental fusion in these cases. And A3 fractures, no doubt, no question, they are unstable fractures, and A4 fractures similarly. So you have to do a bisegmental fusion in these fractures. So let's see some of the examples of these fractures. And now this is what let's see what a burst fracture is. So this is the progression of the burst fracture is, and this is what we already know. These are type A3 or type A4 AO spine, and in the SLIC scoring, this is the burst fracture, which is being given the number 2 points on the basis of the fracture morphology. And this is the treatment algorithm for the vertebral burst fracture. SLIC scoring carrying a total of 4 to 6. So this means that you have to intervene. And what intervention? You can do an anterior cervical vertebrectomy and apply a cage or a spread graft and anterior cervical plating. So this is what you need to do for a burst fracture, like as you can see in this diagram. So this is a flexion compression injury. Stage 3, you see fracture of 2 vertebral bodies over here, C5 and C6. And patient was ASIA C, which is again an incomplete injury, which gives it as SLIC scoring of 3 plus 1 plus 1. This makes a total of 5, which is more than 4, which requires a surgical intervention. And what intervention which I did in this is an anterior 2-level corpectomy and a fixation anteriorly. Patient was young and patient had incomplete injury, and hence this anterior approach was chosen in this. Now, another example of this type A4 burst fracture. Now you see this is a C6 burst fracture. Patient had incomplete neurology, ASIA B. And if you calculate the SLIC scoring, it is a burst fracture morphology, which scores 2, intact PLC, which you can see in the MRI also, and the CT, which scores 0, and incomplete, which is a score of 3. So this makes a total of and plus 1, which is a persistent cord compression. So there is an additional category in SLIC, which is a persistent cord compression, is given a number plus 1. So this makes a total of SLIC of 6, and therefore anything more than 4 in SLIC has to be surgically treated and fixed. So what did I do is I again approached it from the front, because the posterior tension band was okay. So there was no need to touch it from posteriorly. So I did the corpectomy, applied the cage, and fixed it with the anterior cervical plate. So this is what the treatment is recommended. Now coming over to the B injuries, type B AO spine injuries. Now all the B and the C injuries, they are unstable injuries. No need to talk about that, because we already discussed it. And now type B injuries, B1 injuries is basically it requires a posterior bisegmental instrumentation, because in B1 injuries there is a posterior tension band is gone, and similarly in the B2 injuries also. So therefore their management depends upon the presence of the extent of severity of the A component. So for example, if the burst fracture is there, type A4 fracture also is there along with the B injury, we have to deal it 360 degree. You have to do a corpectomy from the front and fix it from the back. So this is how it is done in type B injuries. So let's see about these injuries. Now this is an example of a destructive extension injury, which is a type B3 injury. There is a disruption of the anterior longitudinal ligament. The loading forces are like this. They cause distraction and extension, and skeletal traction is contraindicated, or you had to apply with great caution in these injuries. And if suppose there is only an anterior ligament rupture, then you do an ACDF with plating. However, if in the second diagram, if you see there is a dislocation. This is not a type B injury. This is more severe type C injury. Therefore, you have to do a 360-degree fixation in these. The algorithm for hyperextension injuries, I already told. And this is, again, this is type B injury, and this is a 360-degree fixation that you have done in this. Now, again, this is again a type B2 injury, which you can see. This is a osteoligamentous disruption. In the MRI, you see in the MRI, I have shown with the red line, there is a hyperintense signal at the posterior tension band, and there is a destruction of the vertebral body at C5. This is a type B2 fracture. Patient had complete neurologic deficit, which makes it Asia A, and is scoring of 3. And on the SLIC, this is the burst fracture, and this makes a total of 6 SLIC, and this has to be surgically treated. There is no doubt about it. And this is what was done in the surgery. And need to fix posterior fix because patient was Asia A and therefore and poor GC, and we had to decompress it. So what I do in my clinical practice, if a patient's GC does not allow fixation upfront 360-degree, what I do at least to fix it from front, and then later on, if the patient improves the neurology, then I can support it if required from a posterior aspect. So another distraction hyperextension injury. I mean, this is, you see there is an increased space between the C3 and 4 vertebral bodies that you can see in the figure. This is the type B3 fracture. Again, a hyperextension injury. The patient was Asia B, incomplete spinal cord injury, and this is what was done, anterior fixation only. Now, coming to this type C injuries, as already said, stabilization out is always required in these injuries, and how much fixation depends upon the other component, which are of A or B, which are also present concomitantly with these injuries. So let's see the translational distractive extension injury. I already shown you this slide. If only in the anterior, this is the ACDF plating. If there is a facetal dislocation, then we fix it 360-degree. Now, coming to the facetal dislocations, now this is what already has been discussed, and this is what we see in our clinical practice mostly, and this is one such example which you are seeing down. This is type C injury associated with varying spectrum of B1, B2 injuries or B3 injuries. So this is urgent closed or open reduction is required in these cases. And this is what a floating lateral mass sign, and this is the algorithm for unilateral or bilateral facetal fractures, dislocations of subluxations, and you have to see whether there is a fracture, a compression fracture, or the burst fracture of the vertebral body. Then you have to deal accordingly, as you can see in the slide. And if there is no anterior vertebral body disruption, but MRI shows a disc in the canal, then you have to first of all take care of the disc. Now, this is very important. You have to do an anterior cervical discectomy, you have to do an anterior open reduction, and do an anterior fusion, and then flip the patient prone, and then do a 360-degree from behind. However, if there is no disc in the canal, then you can only do a posterior open reduction of the facets and fixation posteriorly. So this is how you do the facetal dislocation reduction. This has been given in several books, and this is, I need not go into the details of this. These are my hand drawings in my book, Handbook of Neurotrauma and Handbook of Spine Trauma. You can refer it, these diagrams from that book. Now, some examples of this facetal dislocation. This is C4-5 facetal dislocation. You see these are purged facet, bilaterally subluxated facets on CT scan, and MRI shows disruption of the posterior tension band. So this is a distractive flexion injury. This is a type C injury with F4, classified as type C F4 bilateral with complete neurology and SLIC score of 7. So what we did was, this is the anterior, what happened? What we did was 360 degrees fixation anterior. Why it is running again? Anterior and posterior fixation. So another example of this. Another example of C5-6 facetal dislocation. You see, there is this is again a type C injury. Whenever you see a dislocation, this is a type C injury. Whatever is there, you do not have to do anything. So this was again dealt with 360-degree anterior monosegmental fusion and a posterior lateral mass fixation of the. Now this is a very peculiar injury, and sometimes we come across with these cases. Now, as all of you can see, this is ankylosing spondylitis, and this is what these fractures generally present like this in spond patients, and the complete segment is disrupted. So what is required is two things. You need not be perfect in reducing these type of fractures, otherwise you may damage or harm, because these patients have multiple comorbidities, especially lung comorbidities. So a quick procedure with shorter operating time and with the maximum effect has to be chosen. So a long segment fixation, number two, multi-level fixation, at least 3 level up, 3 level down has to be done. In situ fusion has to be done. So this is a distraction hyperextension injury, again type C, SLIC 6, and this is what I did. Right from C2 to T1 fixation, multi-level fixation has to be done to achieve solid, robust fusion. And this is what my take-home message is that stable bony injuries or with minor instability, for example, type A1, 2, and 3 or F1 injuries, they can be managed with soft collar to a maximum, or a Philadelphia collar for a maximum of 6 to 12 weeks. Surgical stabilization is indicated in unstable injuries. And the approach is, of course, dictated by the injury morphology, and most of the cases, anterior approach is our usual Smith-Robinson approach, which is suitable for most injuries. Now, whether to do it right or left is a question of debate. But what I do is I don't apply traction, number one, to the esophagus and the trachea, and I ask my assistant to hold the retractors, and they do. This is a dynamic retraction that we do. Number two, I ask my anesthetist to deflate the endotracheal cuff off and on, and I always do it from the right side, unless until there are certain other special circumstances. So the goal of the surgery is the reduction, decompression, retention, and fusion of the segments with instrumentation. Well, thank you so much for your kind attention, and I hope that I might have done justice to this.
Thank you, Professor Sumit Sinha, and the depth of your research and clarity with which you presented this complex topic made itself a very master talk. And thank you for sharing your expertise with us. And I would also like to thank Dr. Ved Prakash and Dr. Mayank for making the foundation for this expert talk. A few points, I think, from my side, pearls of wisdom. One is that we should always be aware of a skip injury. So when you see a cervical spine X-ray, sometimes it may reach only up to C6. And practically, I had an experience of missing a lower subluxation C7 D1 level with the initial X-ray. And nowadays, most of the centers have polytrauma CT scan. So always we screen the entire spine. The one point is that whenever you find one fracture or one lesion, you have to screen the whole cervical spine. The second most important thing is the AO spine. Dr. Sumit Sinha has told in most detail and explained each part of the AO spine classification. So it remains a practical approach on whether to do surgery or not, whether to find out the instability. As of now, AO spine system is the best nowadays available. The third is the metabolic diseases. He taught about the longer segment fusion. And one thing I want to tell you is that anterior alone fusion can have a problem in a traumatic spine, especially if there is posterior injury associated along with that. And that is why we need a MRI cervical spine. Sometimes we may not see the disc prolapse, And when we go posteriorly alone and reduce the subluxation, this cord can get compressed. Two new things which we have to think about in this topic is one, timing of surgery, and the second thing is role of monitoring during surgery. I welcome comments from other speakers also, but only thing for the base, I would like to say like timing of surgery, ultra early surgery of less than 12 hours is preferred whenever there is a deficit and whenever there is a compression. And time is cord is the concept in a cervical spine injury. Early surgery, less than 24 hours, there is a lot of evidence for that. Stasis study always says that there is a good recovery. So whenever you have a neurological deficit, try for an early surgery. Second is IINM or monitoring during surgery. We monitor for various things. First is in a lower segment fusion or lower segment surgery to prevent a recurrent laryngeal nerve injury. Second, one more thing you have to understand is there can be tracheal injury, which also I had an experience of a patient with long-standing tracheomalacia and tracheal collapse following a cervical spine injury. So whenever you operate on a cervical spine, as Dr. Sumit Sinha told, you should always be careful that the endotracheal tube is decompressed in between. And then in the pre-op scan only look for tracheal injury. There will be signs of that. There can be air outside the tracheal column. All those things we can find in an MRI also. So that will be helpful to look for or follow up in the post-op cases. And third monitoring is MEP. Whenever you are doing a reduction, it's better to do with under MEP guidance or monitoring can be used. And the other thing is that don't use gel form or artificial dura that can swell up whenever you do decompressive surgery and when there is a CSF leak. And I would like to hand over to the other panelist, Dr. Subhash Shantikona, for his comments.
Sir, we want other panelists like Dr. Bernard. Any comments, sir?
Yeah, I think Dr. Jagat has classified most of the discussion so far, and Dr. Sumit has clearly put it. But I still would want to say that early reduction under monitoring is very important because we try to save much of neurological problems. And I have not seen spondyloloptesis being shown in any example, because that's where you have very severe trauma in which one column goes above the other. And we have to be very careful while distracting this because we can further injure the nerve. So that's there. And the role of steroids, which was pointed out by Dr. Ved, I think most of us nowadays don't prefer steroids unless it is very early. So these are a few comments that I wanted to say. And I think most of it was covered by Dr. Jagat and the panelists, the speakers who had spoken just now. The next
Dr. Sumit, Professor Sumit, can you give your expertise on pre-op traction? There was a question from a participant on the role of pre-op traction nowadays in cervical spine injury.
Well, the preoperative traction is required in cases where there is a facetal jump. So if one can remember, then I shown in my slides that you have to be 100% sure that there is no anterior compression when you apply the traction, before you apply the traction, and you have to do an MRI first to diagnose that there is no discal disruption, there is no anterior compression because of the prolapsed disc at the involved segment. It's because what happens is the moment you apply traction, and if there is an anterior compression, after the traction, the compression increases, and the compression has to be applied in flexion. The compression for the traction for the facetal reduction, if you are doing it preoperatively, it has to be applied in flexion. So what happens is if you apply in flexion and you pull it, then the presence of a non-diagnosed discal jump can deteriorate your patient. And of course, it has to be done under awake circumstances, and there are strict criteria about applying traction. You have to serially increase the weight, and suppose the fracture is at C5-6. So you start with 2 kg and then serial increments of 1 kg till a max of 10 to 12 kg is allowed. And with each increase, you have to serially observe for any neurological deterioration. So there is a set standard criteria when you do this traction business in the ward. Patient, of course, has not to be left alone. What I do in my clinical practice is I generally don't apply traction. I prefer to straight away, decompress it, especially when also I was in my AIMS trauma days. So I prefer to take the patient in OT and do the first the close reduction, the close reduction under anesthesia, of course under neuromonitoring. And if at all I'm not successful, I do not fiddle up very much to reduce the facets, especially if the patient is under anesthesia. I straight away do it as an open reduction procedure because that is very, very safe and is not problematic as far as the neurological deterioration is concerned.
Thank you, sir. Sir, Dr. Kuldeep Jadhav, do you have any comment?
Yes, sir. I want to ask uh, Professor Jagannath that he said that don't put any surgical or gel form when there is a CSF leak. Then what is your strategy when there is CSF leak? What do you
Yeah.
do?
I didn't say not to put Surgicel. Surgicel is used as a hemostatic, and issue is that gel form can swell up, especially after a decompressive laminectomy. You have a lot of space. The Surgicel can swell up, and fat is a very good substitute. Using glue is also good. And there has been a report and probably a medical legal case against in a case where this dural substitute has been used and it's swollen up, and then the patient had a quadriplegia. So we have to be very cautious while using that, and you should try to repair it. If it's a posterior approach, you should try to repair it primarily. Put fat, glue. Surgical is good actually; it does not swell up. Now coming to anterior, after discectomy, if there is a CSF leak, usually we put fat and surgical. That should be enough actually. We don't put any dural substitute. Gel form, as I told again, it can help you to control the bleeding initially, but then if you leave it in a closed open space, it can swell up. It can create a problem. And coming back to Professor Sumit Sinha, words about pre-op traction, definitely nowadays, whenever possible, we have to decompress and stabilize. But only thing is in a lower socioeconomic or a place where immediately OT is not available, probably there's still a role for pre-op traction. And then the mechanism of reduction, Parop, he very clearly told in an open reduction, we have to remove the disc first, and then distraction, flexion, and then we have to compress or hammer on the above vertebra. That is a technique used for a reduction in an open reduction of a dislocation.
Okay, sir. If we are doing close reduction and
Yeah.
we got the operation theater and anesthesia, can we do it in under monitoring?
You see, in a
Close reduction.
close reduction, awake patient only you should do. Actually, the pitfalls of monitoring is that in majority of the cases, we are unable to pick up early deterioration in a monitoring. Even in MEP, it is not continuous. MEP is also, whenever we do, it is only what you call periodical. So the moment when you are reducing or we are causing that traction, if there is a cord compression, we'll miss it actually. It will not prevent us from not doing anything. So that pitfalls we have to be very careful when you do it. So Dr. Sumit told, no, as in when we were working in institutes, at that time we used to do awake close reductions actually. That we used to do. So, and we used to keep the patient on traction, gradually increasing the weight over probably up to 5 days to look for any reduction in this thing, subluxation. And it's not subluxation, spondyloptitis cases which we wait under traction. And one more thing is that in spondyloptitis cases, the posterior elements are all fractured and opened up. Thereby, the spinal cord is getting some space. Here again, the anterior compression by the disc is the most important problem. So, as far as possible, early surgery, early decompression, early stabilization.
See,
Sir,
what
one thing more I want to ask you
uh,
that
Dr.
if in a case,
Just the
yes, sir.
advantage, the question you asked, the advantage of the close reduction under anesthesia, the advantage is that the muscles are relaxed. So when the
Yes,
muscles are
sir. Yes, sir.
relaxed, is that you can get a definitive reduction and your surgery becomes easier. So, but then this carries a caveat of having a neurological deterioration despite you monitoring it neurophysiologically. So in my practice, I used to do it before, but nowadays there are very few instances that I can recollect that I do it during before the surgery. I mean, so not before the surgery in the ward or the ICU and not in the operation theater. So my practice is basically to open it and only open reduction, that too under neurophysiologic monitoring.
Exactly.
Sir, I do agree because I think that the close reduction is, uh, I mean, somewhat historical thing.
Yeah,
Yeah.
absolutely.
And sir, just I want to ask you, what was the maximum weight if we were doing close reduction? Because you had also seen those eras when close reduction was a compulsion to us. So, what was the maximum weight? Because Jagatlal sir is saying that we used to increase the weight for at least 3 days. So, what was the maximum weight for a first fashion?
So I still remember my residency days in AIMS, the cases with cervical dislocation or atlantoaxial dislocation. We used to, we have been taught about to apply tractions, and if the traction not found in the next day morning rounds, I mean, you are sure to get severe bashing. So, let me tell you, the maximum reduction, the maximum amount of weight that you're allowed is, if you go by the textbook, this goes up to 1/7 to 1/10 of the patient's body weight. So if a patient weighs about 70 kg, then I mean, at the most that you can do 10 kg or 12 kg at the most. And how you start with is uh, basically you start with 2 kg initially and then 1 kg for every level. So if suppose C5-6 vertebral dislocation is there, then it becomes around some about 7 to 8 kg. So and then you have to serially increase it, not at once. If you are doing it pre-operatively, you have to give proper time, and you have to, of course, as I mentioned, you have to observe the neurology of the patient also.
Sir, actually, I had gone through a very old orthopedic book. In those eras, only X-ray was available. That was saying that if the neurological deficit is there into the patient, we should try to reduce the cervical spine as early as possible. For that, first of all, we put a 5 kg weight, and then every 10 minutes we increase 2 kilo weight up to the 30 kg.
30
Actually, it is
kg,
like
yes, very right.
5 pounds per
So,
level. That is a thing. And see, these are all historical textbooks, but then in the modern medical
nowadays,
legal era,
remember,
we should be very careful.
Okay. Sir, I want to ask a question from Sumit sir that what is the strategy in first I want to ask that what is the strategy in dealing with cervicothoracic junction fractures, and second of all, when a fracture which separates the vertebra into two columns, the superior, the cranial and the caudal, there is complete disjunction
disjunction,
between these
disjunction has
two.
happened.
Yeah.
Disjunction has happened. Okay,
Kind of a
so
chance flat.
both of your questions, they will require at least an hour-long discussion and talk. So because CT junction injuries, they are a topic in itself. So when you encounter the CT junction injury, I mean, first of all, there are a few broad principles you have to keep in mind that I mean they have to be fixed 360 degree, because this is the transitional zone. So you have to fix anteriorly up front and posteriorly as well. And posteriorly, there has to be a at least 2 level up and 2 level down. Of course, depends on the morphology of the fracture, what it is about. And sometimes the important problem with these fractures is that, especially in a thick patient, in an obese patient, I mean, and going beyond below the D2 vertebral body is not possible. So you have to take the help from your cardiovascular team to expose the do a meningotomy and this or sternotomy, and then so that you can expose beyond D2, below D2. However, in a thin patient, I mean, you can easily approach till D2. So again, in these patients, preoperative X-ray and preoperative CT scan will tell you as to what level is accessible, and you have to carefully see those scans and X-rays before you go on to do an anterior cervicothoracic junction fixation. To answer your second question, the disjunction, of course, this is again a three column injury through and through. This is a chance fracture, and you have to, of course, it is a highly unstable injury. Aggressive pattern of injury is there, and you have to deal with it. And mostly, 99.9% the patient will have a complete neurology. So the surgery, the aim of surgery will be, in most of the circumstances, will be the rehabilitation of the patient, so that he can at least sit wheelchair, move around, so that the physiotherapy post-op becomes easier, and the other problems of quadriplegia, like problems in the lung and bed sore, etc., they will be minimized. So you have to do a 360-degree fixation again, anteriorly and posteriorly, in these injuries.
Okay, sir. Thank you.
Sir, can I add few things?
Yeah.
Sir, in continuation to what Sumit sir has told, sir, in our center, we used to put the patient in the CT gantry before taking to OT, once we are taking the CT scan of the patient, with cervical collar along with a shoulder wedge over the back of the shoulder blades, so that it exactly simulates the clinical position of the patient as on the OT table, so that we should not get surprised that his manubrium sterni is too high to access the T1 or T2 vertebra. So after getting the CT scan, we see the angulation of the manubrium sterni to the vertebral column. What is the angulation, how much we can access, and depending upon that, we arrange the surgical team. As you very well said, that we should take over the help of our CVTS surgeons for exposure of the upper thoracic vertebra. So better to get aware before taking the patient to the OT than get surprised on table. So this is a small clinical trick which we can use to measure the angulation and how much we can go by seeing the sagittal view of the CT scan.
Thank you. Well, so any further questions, or because it will be going on because it's a very interesting topic and there is no end of discussion. So if there are no questions, Deepak sir, you want to comment anything?
Sorry, dear. Actually, I was not listening to this. I was in a flight. So I just heard that very nice discussion was going on, and it is very fruitful webinar. And we'll put this all on YouTube, okay, for NTSI members and everyone to see later on. And I myself will watch this. Okay. Hello.
Yes, sir.
Yes, sir. Yes, sir.
Okay.
I,
Okay.
I
Thank you, sir.
myself will watch this. I'm in Udaipur right now. I just landed there. So thank you on my behalf to all the speakers, Dr. Ved, Dr. Mayank, and obviously Sumit sir is always leading the way for the Neurotrauma Society of India, and to all the panelists, Dr. Kuldeep, Bernard, and everyone. And I hope this will continue, and the people will get insight into these things that are very common day-to-day practice, but somehow we are missing the technical part and missing the legal part or missing the literature part of how it should be actually done. So thank you very much from behalf of NTSI. And
Sorry, sir, Deepak sir. I just want to ask last two questions to Sumit sir. What is your take on dynamic X-ray after the stabilization of a patient who don't have any neurological deficit? And second,
Say that again. Sorry.
what is your take on the dynamic X-ray in a patient who has been stabilized and who don't have any neurological deficit?
No, if already stabilized, then there is no need
There's
for
no
that.
need of it.
So, I mean, dynamic X-ray is done only to see the instability. So you have already fixed. So there is no instability now. So the only
No, sir. No operation have been done. The patient is neurologically intact. He has he has been managed as a patient of trauma, but
no fixed has been done.
on MRI, some hyperintensity is seen in the posterior
Yeah,
ligamentous
follow-up we
complex.
always do after 6 weeks actually. After 6 weeks, we do follow-up flexion extension in such cases. And it's always better to do a CT flexion extension as it is very clear. If possible, do CT flexion extension.
Okay, sir. Okay.
Welcome all to Neurotrauma
And
Conference
sir,
at Hyderabad,
one
August
last
7th, 8th, 9th. Yeah, tell.
Kuldeep is asking. Yes.
Sir, one last question that in literature it is mentioned that sometime disco ligamentous complex at the time of impact hits the spine and causes central cord syndrome. And then when in a MRI you see there is no protrusion of disco ligamentous complex inside the canal and no instability in the dynamic X-ray, then, sir, what should be done in your point of view?
So what you are talking about is probably Cyvora.
A0, A1.
Yeah, Stivora. Yeah.
Normality. So I mean, these are very not uncommon injuries, I would say, and they are also known as whiplash injuries, commonly in children less than 10 to 12 years of age. So what is the best practice for dealing with these lesions is just observe initially and follow the clinical course as to what is happening to the patient, and then but of course after excluding all treatable causes or all those compressing causes for a spinal cord injury. You have to do an MRI, you have to do an X-ray, you have to do a CT scan, you have to do dynamic studies and exclude all the compressing elements which are causing the injury to the spine. In these cases, some people also recommend dynamic flexion extension MRI studies as well, because it has been seen that sometimes dynamic movements of the spine, they cause compression more in flexion as compared to extension, and they keep on hitting the spinal. So you have to exclude everything, and if everything excluded suggests that this is Cyvora, then wait for some time, 4 to 6 weeks to 8 weeks for children to improve, for patient to improve, and most of the kids, they do improve with this after some period of time.
Okay, sir. Means conservative. We will be conservative. Thank you, sir. Thank you, sir. That's all. That's all.
Sumit
Yeah,
sir.
thank you so much. And I think we should conclude now.
Yes.
And welcome, invite you all for the Neurotrauma Conference at Hyderabad, August 7, 8, and 9. There will be a lot of discussions like this, and see you all there. Thank you, Dr. Arun Sharma.
Thank you, Ved.
All the panelists, and speakers made this gathering wonderful, and looking forward for all of you next month in Hyderabad. Thank you so much. Bye-bye.
Thank you.
Bye, sir. It
Thank
was
you.
nice
Thank you, sir.
meeting you.
Thank you.
Good night, everyone. Bye.
Good night.
Thank you, Dr. Arun Kumar
Good night,
Sharma.
sir.
Thank you.
Good night, sir.
Good night.